So then I'd like to welcome you all, brave souls, on this lunchtime poster session. I was assured that there will be lunch left over after the session, so that's our only hope. We have on the agenda a total of 11 posters, but right now I don't think we have all the presenters here, but we just stick with our timing that we have 5 minutes per poster. And then, of course, if you have from the audience any questions, we'll take them after each presentation. So, and then we can, is that working already? Yep. I'm not sure, Una Convery, if you are here. That doesn't seem to be the case, because then Sue Molesworth is going to lead us off with dementia care in an English integrated care system. And that's yours. So, welcome and happy to hear what you have to say.
Thank you. Yeah, great. Good afternoon, everybody. And first of all, I'll introduce myself. I'm Sue Molesworth. I'm based in England in the West Midlands at the University of Keele. But I want to start with an apology. I'd expected to be able to share some preliminary results from the study we're developing, but we've had delays in a very protracted research ethics process. We made the decision, having started with a practitioner study, to then go for full ethics approvals to include participants who experience care, so people living with dementia and their care partners. And this is what I'm going to talk about, how the progress that we've made on this study. Our focus is dementia, which I've mentioned, and we are 3 research fellows funded by the NIH and Alzheimer's Society, who've put in a huge amount of funding to build research capacity in dementia. And in fact, there's about 60 fellows in England. 3 of us are in the West Midlands, 2 at Keele, 1 at Birmingham University. We're looking at social care practice, the place of dementia in integrated care, and lived experience of people living with dementia and their care partners. And our study is going to focus on the experiences and perspectives of practitioners, and also lived experiences and perspectives of people about integrated care. So what is it like to be in receipt of care through an integrated care system? We've got an active patient and public involvement and engagement group. This is people living with dementia and current and former carers, and they are helping us to shape the study. They've helped us to identify some of the key issues from a lived experience perspective, and those perspectives are informing both our interview and our observational work. And some examples from our PPIE group, the importance of care partners, and I know this has come up already this morning, care partners, carers, family caregivers, just a different term. How do services support them? Mindful that carers struggle to navigate very complex services for their family member with dementia. And for people with dementia, their need for meaningful interventions and support, particularly culturally appropriate support, was highlighted. We're at the stage where we've got all our materials. We're ready to submit for ethics, HRA full ethics approval, and we hope to start data collection in the next 2 months. We've decided we're going to use non-participant observations because we want to see what happens in practice. So we're going to observe care appointments between practitioners and the person with dementia and their care partner. This could be social worker, practitioner from the voluntary and community sector. It could be another care worker from statutory sector. And we're going to conduct interviews, semi-structured interviews as well, people with dementia care partners, practitioners. We may also do additional data collection with using focus groups and some consensus work as well, we hope, through Delphi or other that is accessible for all participants. We have very good links with our local social and health care services within our integrated care system, which is Staffordshire and Stoke-on-Trent area, covers quite a large area of the West Midlands. And we've also visited local groups to meet and talk with carers and people living with dementia. Alongside this study, we've got some other strands of work. We were successful in getting funding for 3 PhD studentships, one of which will be interdependencies between primary care and social care, and we think that would be really valuable to support the capacity building in dementia research and feed into the integrated care strand. We've got some NIHR funding for interns who will be working with us and support the research fellowships. We've developed a logic model based on policy, and we're going to use that to engage with our local system leaders, implementers, and we hope from that we'll be able to gain insights into some of the challenges around local implementation. And we lastly have funding applications looking for further resources so we can build and develop a very substantive programme of dementia research. Thank you.
All right, thank you very much. Having just come from a conference in Germany on dementia care where we were a lot more discussing problems and not so much solution, I find that very relevant. Thank you. Are there any questions from the audience? If that is not the case, thank you very much again. And then I'd like to ask if Jenny Person-Sowacki is here. You're there. Welcome. Then I'd like to invite you up. And we're now talking about diabetes psychology. So.
Yep, so my name is Jenny Pearson. I work as a diabetes psychologist in West London NHS, specifically clinical health psychology, and I'm based in Diabetes Integrated Care Ealing. So I'm here today to present my poster that I did with other team members, and it's very much about how to integrate psychology into diabetes care pathways. It's based on the stepped care model that we use in mental health. So it goes on the level from 1 to 5, where at level 5 it's the more intensive psychological issues, and at level 1 it's minor psychological issues. So I was asking myself, does diabetes fit into an integrated care pathway, to a stepped care? And I just realized that it doesn't really, because what might be seen as a mild problem in mainstream psychology, i.e., for example, mild anxiety, can be seen as more of a severe issue. So I think the steps are not really aligned. For example, if you have a mild anxiety, a phobia, that might be seen as a fairly minor issue that can be dealt with mainstream psychological services. Whereas in diabetes, if you have, for example, needle phobia, it can easily go up the stages until a very more severe condition. So that's why I really wanted to have another look at this. And I have been using the steps as outlined by one of my colleagues who has amended the steps a little bit more to suit patients with diabetes. And where do I come in then? So I am very much on level 3, level 4, and I see people with more severe issues and also specific diabetes distress. I have developed an integrated group together with expert diabetes who provide a nice approved group of structured education. So I have taken integration a step further to actually integrate a psychological intervention with that of structured education. It's very much early stages. So the data here is based on 10 patients. I'm yet to write it up as a pilot, so I'm very pleased and happy that I've had this opportunity to come and present the early results here. So that's part of it where I'm more involved with that particular group. I also see patients individually. So I also have to decide and agree with the patient who would be suitable for the group, who would like to be seen individually, and it's very much based on choice and what their preference is. There won't be too much time today to describe the group in detail, but I can also maybe describe other interventions that are happening. I think we are quite blessed in Diabetes Integrated Care Ealing in DICE, which is based in Southall. We actually have many interventions developed by now and a lot of support, so we are able to draw on help and support from a lot of different services, including health coaches that come in and help on a level 1, and that is milder psychological issues, but also perhaps where the diabetes have not started to impact on their life so much. And we also have a mainstream structured education program that everyone with type 2 should be offered, but it's not always happening. So, and then we can also draw from expertise from IAP. They have recently changed their name to Talking Therapies, where we can actually refer people who have psychological issues and in combination with diabetes, they have some specific training. And then my service comes in a little bit in parallel, but also more specifically to people who are referred to the team, where they also need to be seen as psychologists in the team, and I have the benefit of being fully integrated into the team, so I attend multidisciplinary meetings with the nurses as well, meaning that issues that might come up in my sessions, whether group or individual, I can then talk to the nurses about. And I know not many type 2 services across England have got this benefit. And then, actually, very interesting, on level 4 and 5, I brought in some work there from my colleague, Priscilla Gombe. She is a nurse in the service who established that we actually got 8% of our patients have got mental health issue of kind, and many severe. So we are thinking, how do we integrate further with more secondary mental health services? And actually recently, last week, we set up a meeting with our secondary care team where we were able to kind of find a way of co-working to think, how does the diabetes affect their severe mental health issue, and vice versa. So although we have some interface with the technology, it's not fully set up, and we also need to have more online meetings and together have a space to discuss these patients. And that's where I finish. Thank you.
All right. Again, thank you very much.
Thank you.
And I think, another very relevant topic of bringing
Yes.
this kind of psychological care with the actual morbidity together.
Yes.
Are there any questions from the audience? Yes.
I was interested about the idea of sort of people have multiple issues and one condition rarely comes on its own. And it's sort of integration of services you mentioned tonight. It's just made me think about practitioners' knowledge of integration, about how you have extra knowledge that could help with that with people with multiple difficulties. Just sort of popped into my head thinking of integration, what that also mean about knowledge integration.
Yes, and I think that's particularly relevant to diabetes because it affects all systems of the body, and as this condition progress, or ideally do not progress, thanks to better preventative strategies. But I think these meetings and sharing knowledge and also allowing time for presentation, case studies is kind of part of the integration as well. Thank you.
Right, thank you. And then we're going on to Miho Takeshi from Japan with a study on healthcare costs during the last 5 years in elderly people with long-term care conditions. Welcome.
Good afternoon. My name is Miho Takechi. I'm a physician at a community hospital in a rural area in Japan. My town has a population of 19,000 with an aging rate of 38%. Long-term care insurance, LTCI, covers 1/5 of the elderly population, and women typically have longer LTC periods than men. Long-term care facility are relatively well established there. I'll discuss our research on total healthcare costs that integrate medical insurance and LTCI for elderly individuals in their final 5 years of life, assessing differences by gender, age, and location of death, focusing on hospital-based versus community-based end-of-life care. We examined 96 individuals over 75 who were initially LTCI certified since 2016 and deceased in 2021. Figure 2 shows the healthcare cost trends over 72 months before death for individuals with color coding to indicate different types of expenses. Red for hospitalization, blue for outpatient, green for home care, and yellow for facility care. This offers a clear view of spending patterns and the progression of care from medical interventions to long-term care support right up to the end of life. We also categorized the location of death into hospital death for those with inpatient costs in the month of death, and community death for others. And Table 1 displays the healthcare costs across gender, age, and location of death. Figure 3 shows gender-specific healthcare cost. Blue bars for medical insurance and red bars for LTCI costs. We found that men have higher medical costs while women have higher LTCI costs, suggesting a need for gender-specific healthcare strategies. Figure 4 indicates that individuals over 90 had lower medical costs, favoring community-based long-term care. Also, Table 1, community deaths were linked to longer facility stays and higher final care levels, suggesting complex needs. In contrast, hospital deaths resulted in much higher costs, underscoring the financial impact of hospital-based end-of-life care. In our town, our study emphasized needs of in our town, focusing on facility care could greatly improve our integrated care systems. In conclusion, our study emphasized the needs of personalized care plans to enhance the shift from hospital to community-based care at the end of life. Having said that, Japan's LTCI system appears to have gradually improved, suggesting a positive trend towards community-oriented care. Thank you for your time.
Thank you very much. I was just told we need to speak into the mic because we're being live streamed. Thank you very much for your presentation, and let me just take the opportunity, because you were referring so much to your figures and tables, which of course we cannot really read here. All those posters are also being displayed in the hall where lunch is being served on big screens. So if any of this captures your fancies and you would actually like to see the cost data, then it would be a good place to go there in the lunch break or one of the breaks where you can look at the poster. But now, are there any questions on this presentation? That's not the case. Then, again, thank you very much. So, and then we're moving on to Calgary, and I'd ask Yolanda Martens on the integrated community care model and its impact.
Good afternoon, everybody. Good morning, Canada. My name is Yolanda Martens van Hils. I work for the Calgary Foothills Primary Care Network, which is guided by your family physicians in Alberta. Integrated care is most effective when the system is built around the patients, rather than requiring patients to navigate multiple systems. This was our guiding principle behind the Calgary Foothills Primary Care Network Case Collaborative Program, initiated already over 7 years ago. We've put patients at the center of their care. So why did we make this change? Traditional healthcare was confusing for patients. They struggled to find their way through the different services, especially those with history of trauma, mental health, addiction issues. We saw this in feedback from patients. So unfortunately, in 2014, Cochrane, which is a very small town in Alberta, close to Calgary, had several youth suicides. In our Calgary area, West Bow area, had many elderly people lived alone with high-risk needs. So we saw these urgent issues. So we worked with community partners to create a joint collaborative care model, and we created 4 case collaborative tables with over 70 agencies involved. This work helped us to break down barriers in healthcare and offer more comprehensive services for our patients and families. What guided our work? We focused on tailoring healthcare to each patient's needs. We worked with a diverse group of professionals, which led to better connections and shared responsibilities. Everyone involved takes ownership of this work. Our journey taught us the importance of understanding patients' challenges. Strong relationships among providers make big difference in how we deliver services. Things like involving patients, having a good governance, and making referrals easier have been crucial to our success. With family satisfaction over 99% since 2017, provider satisfaction of 97%, which 85% of those providers believe the model facilitated timely connections to resources, 91% believed it enhanced patients' quality of care, and all of them 100% empowered to provide shared care. Patients reported feeling better supported, emphasizing the collaborative team's significant impact. The strengthening of relationship among providers have not only benefited patients directly, but it involved and have created a ripple effect in our communities, improving the overall service delivery in the community and better provide capacity, positive effect, and healthcare system. If you'd like to hear a little bit more, we present on the details of our challenges and our learnings and our journey towards patient-centered care during our session 4 from 2:30 to 4 in room 2B. Thank you so much.
All right. Thank you so much for presenting this. And are there any questions from the audience? Yes, over there. I'll come to you with the microphone.
Hello, Calgary. I'm Ontario. So I wanted to find out whether your system or your supports that you have or your model, does it support individuals, all individuals, those with disabilities, without disabilities, so the entire population?
That would be our dream. I think that would be really when we spread and scale. So we tested it before. Our population needs were on the older adult and the child and youth, because we saw those are the two populations that really needed that comprehensive care, especially when there's multiple agencies involved, multiple providers. Families are at loss, and that's where we started. But absolutely, this could be spread and scaled to other populations. One of the areas that we've seen in Calgary right now is the emergent adult. There's gaps in care when a child and a youth grows into that adulthood. How do we support them? So that's our next one.
It's great to hear about the transition age. Thanks.
All right, then. Thank you very much again. And we're taking a look at COPD, if Alison McAllister is in the room, which she isn't. And I also don't know. Are you there? Sorry.
That's okay. That's okay. Good afternoon. My name is Alison McAllister. I'm a clinical nurse specialist working in respiratory integrated care in the Dublin North Central area. Respiratory integrated care is focusing mainly on the respiratory diseases of COPD and asthma. We aim to manage people with these chronic respiratory diseases in their communities, and in doing so reducing the burden on hospital outpatient clinics and ultimately preventing hospital admissions. The focus of our poster is earlier diagnosis of COPD. We know that less than a third of people living with COPD have actually received a diagnosis. The guidelines issued by the Global Initiative for Chronic Obstructive Lung Disease states that spirometry is vital to establish their diagnosis. So the aim of our poster was to demonstrate that through nurse-led clinics, we enable earlier access to spirometry and earlier diagnosis via consultant-led multidisciplinary meetings. So we collected data from May 2021 to May 2023. We included all patients that were referred to the nurse-led clinics with a presenting diagnosis of COPD or query COPD, but who had no previous spirometry testing done. Or we excluded anyone who already had a diagnosis of COPD confirmed by spirometry, or anyone who had any other confirmed respiratory diagnosis. Our results, we had 99 patients in total that we included, and they all proceeded to have spirometry testing done in the Mater Hospital in Dublin, and their results were then reviewed at our multidisciplinary meeting. You can see on the pie chart that it was interesting to investigate those 35 patients who did not receive the diagnosis of COPD. The access to spirometry for these patients prevented them from being treated inappropriately. The majority of those patients diagnosed, you can see on the bar chart,
were diagnosed with GOLD stages 1 and 2. So the grading indicates the severity of the obstructive lung disease. So the lower grading indicates a lower severity and earlier disease. So it is important to note that these patients were diagnosed earlier in their disease process. So our learning from this poster is that we know that our service enables improved access to diagnostics, and it provides input from specialist clinicians to ensure correct diagnosis and treatment. We know that appropriate treatment can then start earlier. It gives us opportunity for education with these patients on lifestyle changes to minimize the impact of their disease progression. We know that secondary prevention and early intervention will improve outcomes for our patients with chronic illnesses. Our services continue to develop across Ireland, making spirometry testing and specialist clinical input more accessible to our GPs across the land. In the future, our service plans to review our patient satisfaction rates and to gather further information on the effectiveness of our service. Thank you very much.
Thank you. Are there any questions? I have this issue of underdiagnosis. Do you know why that is? Why current diagnostic rates are so low?
I'm not sure 100%, but I imagine that people just don't present. They have cough, they have phlegm, they may have a history of smoking, and a lot of people will put their symptoms down to the fact that they have smoked and they don't seek medical treatment.
Okay, yeah. I was just wondering, given how severe the symptoms can be for the person, that they just, okay.
Yeah.
All right. Thank you. Then we're going to Volker Amelung, whom I really haven't seen yet, and who also doesn't seem to be here. Then we're going on to Albert Alonso on serendipity in integrated care.
Thanks, Ingo. Good afternoon, everybody. I was, when having the chat with Ingo, I was telling him that perhaps this is not an oral presentation that should be presented at our conferences, because it has nothing to do, actually, with integrated care. But I think that by the end of the presentation, you will realize that there is a sort of learning issue that has a little bit of value, and that I think that it's the reason why we decided finally to submit it as a poster. So everything started back to 2018 when, in another group that I am also involved, started to explore the possibilities of using artificial intelligence in order to have artificial intelligence enhanced algorithms to better supply oxygen to those people that are in need of continuous oxygen supply by using portable equipment. That was basically the idea. Now, one of the challenges when you are in this world of artificial intelligence is that you have the need to actually integrate the algorithms, right? And in order to do that, you basically need data. Now, from our clinical perspective, the reference for us was the 6-minute walk test, which actually provides data in a rather controlled environment, being the main issue that it is a type of that is mostly performed in lung function labs on a manual basis, so there is no technology supporting that data collection, right? So basically what the engineer, oh, sorry, was it right? That's the one, yes. So basically what the engineers suggested us was just to make an automatic version of the 6-minute walking test. Now, 6-minute walking test is just a test that measures the distance that the patient can quickly walk on a flat, hard surface in a period of 6 minutes. And it's really useful, specifically when they are using it to understand the global response of a given patient and the systems involved during the exercise. That is basically the idea that we have as clinicians. And it basically expresses the limitations of your pulmon, your lungs, and your heart. Basically, that is the idea. For most of the patients, actually reflects the maximum amount of effort that they are able to perform on a daily basis. And it's usually done by professionals working at the hospital departments. Now, what the engineers did was basically to come up with a solution that is based with two light beacon devices. Is that sword at the top of the cone that has the shape of a donut, and you can see a blue light there, so that is the beacon device, right? And that marks basically, the cones mark basically the walking course and detect the patient as they are just turning in the right direction. Now, they also develop an app that could actually capture the data, also synchronize the data with data coming from a pulse oximeter, and then they develop a desktop web-based interface in order to have a better details and better understanding of the overall performance of any given patient. So that was the idea, as simple as that. And then what we did was just to run a cross-sectional study to demonstrate that the data that we were collecting was exactly of the same quality that the data that was being collected by our technicians at the lung function lab. And this was demonstrated. But then we realized that the solution was a very good way of making the process more standard, even for those that are not that used to actually doing the 6-minute walking test on a manual basis. And that was very important because it has a number of applications, not only in other areas beyond those that are more related to lung diseases or heart diseases, but also in the areas of rehabilitation, geriatrics, oncology, and even beyond, because the 6-minute walking test is usually used by pharma companies in order to establish if any new drug has any influence in the capacity of gait, walking, etc., right? So the moral is that as a result of that, and because I am also involved in the developments around integrated care at my hospital, we started to think about whether there would be any chance to transfer, this technology to the primary care level, right? And because of them developing a full program from our hospital to support, primary care physicians or technicians at the primary care level to actually run this test. And the potential benefits, if that is successful, and it has not started yet, is that a program like that could be closer to the patient's follow-up. So in a way, we would be moving, the follow-up complexity to a primary care level, which is much better in many ways, right? And therefore, it would increase the system level efficiency. So the moral of the story is that something that started from a research that was not at all connected with integrated care might end up with something that is meaningful in the area of integrated care. Many thanks.
And that's the best kind of research, isn't it?
It is, yeah.
Thank you, Albert. Are there any questions or any people interested in getting 2 of those cones and try them out? I was just thinking, because actually our next paper will be on oncology, so maybe that's something to pick up. Albert, thank you very much. And we're going to Chiara Partiman and oncology care as integrated care. Welcome.
Okay, thank you. My name is Ciara. I'm a clinical nurse manager too. I work as a liaison nurse for the South Dublin Community Intervention Team and for Tala University Hospital. So part of my role is to create pathways between the two services, and this particular pathway is between the Oncology Day Ward in Tala Hospital and the South Dublin Community Intervention Team. The background to this, it was interesting, I think it was mentioned this morning at the first plenary session about demand and capacity, so it kind of sits in right there. So it's about cancer care. It remains a global health challenge. So back in 2018, the WHO released figures of 9.6 million deaths per year. The International Agency for Research on Cancer estimates that new cancer cases will rise to 27.5 million by the year 2040, so triple its number from 2018. And then in the context of Ireland, our data shows that cancer stands as the leading cause of mortality in the country, with projections indicating doubling of these figures by the year 2045. So again, kind of going back to demand and capacity, albeit very small changes, we're putting in these changes now. So the implications of all of this is an increased patient load, resource allocation, financial burden to both the healthcare systems and the patients themselves, access to care, and importantly, impact on patient-centred care. So our solution to this, in this ever-changing landscape of healthcare, is to implement a pre-chemotherapy clinic. So by bringing these essential elements of pre-chemo care out to the community, we're not only redefining a patient experience, but we're also trying to create a model that will potentially alleviate the hospital congestion, create capacity on our day wards, and hopefully amplify nurse-patient relationship. So just a brief introduction to CIT. CIT in Ireland, they're run by the Health Service Executive. They're a nurse-led service, so we have no clinical governance other than the referring clinician. They operate as a nursing response team for a patient with acute care needs. So they can look after a patient in their own home, and that includes nursing homes, or they can offer clinic visits. There are currently 4 clinics dotted around South Dublin. So this poster explores the pathway. This is, January would have been a year since this was implemented in the Kilnamanagh Primary Care Centre. So the CIT clinic opened initially for 2 days, 1 day a week, and it was a very limited capacity of 5 patients. We wanted to make sure we were introducing this very slowly and very safely for patients. Due to its success and demand, we then opened 2 days a week, so a Monday and a Tuesday. The number of services provided also expanded. It originated as a phlebotomy clinic. So the day before or 48 hours prior to their chemo, a patient could attend the community centre. So the number of services expanded now as well. So now expanded scope to include PIC care, port flushes, GCSF administration, and 5FU disconnection. So some of the outcomes noted, again, I know this poster is really tiny. Some of the outcomes from a patient perspective, the biggest thing was their waiting time was cut down when they arrived in the day ward. So because the blood results were ready to go when they arrived the next day, they were straight into the day ward, a quick nursing assessment, and their chemo could then be confirmed with the pharmacy. So there was no waiting around. It effectively cut down the waiting time as much as 3 hours per patient on the day ward. Enhanced clinic access was also shown to reduce missed appointments and improve the patient's treatment plan adherence and reduce costs for the patient. So the Irish Cancer Society showed some results there. It was €291 per month per patient associated with visiting the hospitals. This has cut down some of that cost. The CIT clinic offers free parking. There's no waiting around, so no popping down to the canteen while we're waiting for your results. Hospital outcomes then was resource optimization was huge, and time management, especially the oncology day ward staff noted a lot of time, and what they've done now with that time is they've facilitated protected time for staff education. So challenges in this age of digital technology, we have none. So there is no ICT infrastructure between the CIT and TUH bar and email. Currently the referral process is a paper-based one. There is no PC access in the CIT clinic, which would obviously ease communication between the two services. One such communication piece is we also note some patients forget to bring their blood forms with them to the clinic. If that happens, we just run a full profile anyway. It doesn't mean the patients can't have their chemo the next day, but we could be missing out on specific blood requests like cortisol levels or magnesium. The clinic is also closed on bank holidays. It's a primary care centre in Ireland. We close on bank holidays, and the clinic is dedicated to a Monday and a Tuesday, so every bank holiday is closed, which reduces down the accessibility to 1 day per week. Our figures are really good this year so far. We've seen up to 200 patients since the start of the year, and the next step to this are we're going to follow a few patients on their journey just to really make sure that the journey from start to finish is a quality-based one for our patients. And that's it for me. Thank you.
Right, thank you very much. No ICT integration. Where have I heard that before?
Yes. I believe a global issue, but yeah.
Are there any questions from the audience? That's not the case then.
No,
thank you very much.
Thank you.
Then I'm wondering if Julia Gawronska is here. That doesn't seem to be the case. Then we're coming to our last presentation, Jennifer Rayner, Sarah Hobbs, on Health Equity Charter in Primary Care in Ontario.
Hello, my name is Sarah Hobbs, and I work for the Alliance for Healthier Communities in Ontario, Canada. The Alliance is a provincial association that represents community-governed, comprehensive primary healthcare organizations. Our members offer a range of services, including clinical services, social services, mental health and addiction supports, and programs that address the social determinants of health. Our members include community health centers, nurse practitioner-led clinics, community-governed primary health teams, Indigenous primary healthcare organizations, and others. One of the things that is somewhat unique about our members and sets them apart from many other primary care models in Ontario is their focus on health equity. Our members address inequities. What those health inequities are depends on their location and the needs of the community and people accessing their organizations. This focus on health equity led our members to come together with the Alliance to develop a health equity charter that members sign on to as a commitment to advancing health equity in Ontario. By signing on to the charter, the organization is making a commitment to work towards improving health equity, which improves experiences and outcomes for the people and the community that they are serving. The charter was first developed in 2012 and was refreshed substantively and expanded in 2019. Developing the charter was a highly consultative practice that included consulting with the Alliance's primary populations that include Black, Indigenous, 2S LGBTQ+, Francophone, and rural, remote, and northern people. We also completed an environmental scan and consulted with our members. The members approved the Health Equity Charter at an annual general meeting of the Alliance and agreed that signing the Health Equity Charter would be a requirement for membership with our organization. The Charter is a living document that includes calls to action at the system level, the organizational level, and at the individual level. It is a tool used to advance health equity through a human rights and social justice approach. The Alliance supports members' adoption of the Charter by offering a Governing for Health Equity training series for leaders and board members, as well as webinars and a self-assessment tool that includes a handbook with resources. The self-assessment tool is completed annually by members and shared with the Alliance. It is meant to be a tool to determine where the organization is at with regards to the commitment to the Charter. It is not meant to be a report card or a test, but rather a tool to reflect on what strides have been made and what next steps might need to be. Examples of next steps could include updating organizational policies, reviewing intake processes, determining training needs of staff, reassessing services offered, or participating in advocacy. We have heard from our members that completing this assessment has assisted with accreditation and informed strategic planning and operational planning. While the Health Equity Charter was developed by and for our members, who are primary care organizations, as integrated care is being developed and implemented in Ontario, our members are sharing the Charter with their regional integrated care teams called Ontario Health Teams. Some Ontario Health Teams are adapting elements of the Charter, and some are interested in adapting the self-assessment tool so that it can be used at the integrated care system level. The Charter has enabled members at the local level to make changes on how they approach care, the services they provide, and in other ways. The Charter at the system or provincial level has informed our advocacy work, and whenever we meet with decision makers to discuss policy or regulatory changes, we do so using the Health Equity Charter as a lens to provide input and feedback on health system changes. The poster has a QR code, so if you're interested in learning more, please check it out.
Okay, thank you very much for your presentation. Are there any questions? I would actually be interested in knowing, do you do any evaluation in terms of, for example, if the rate of events of discrimination or stuff like that is going down, or so what the impact is in terms of the actual goals of the Charter?
So I think that the goals of the Charter are to provide a calls to action, principle statements, ways in which we think that the healthcare system should work for everyone. And so with that lens, we're able to enable organizations at the local level to develop those plans, whatever those might be, and that often gets embedded in their strategic plans, attached to their indicators, attached to their key performance indicators. So it's more at the local level that organizations are using the Charter that way.
All right, thank you.
Here we are. And with that, I would like to close this poster session. We were able to end a bit early due to some people not showing up, which gives you access to lunch a bit earlier. Thank you very much for coming. Thank you very much for staying the whole time, and enjoy the rest of the day. Bye-bye.